start? So next is location and number of implants. Depending on the location and thing. Dish, consider that. You have an option of getting a CBCT done which will give the exact measurements, or else we can do your bridge mapping. Okay? So this you have to keep in mind and place the implant size accordingly. Raise the flap. Again, you will hear people talking about flapless implant placement. Please don't start your flapless implant placement as your new practice. It's very risky. Very commonly you go wrong. Okay. So no flapless until it is a CBCT guided guide. If there is a CBCT based guide, implant guide, then yes, then you can even close your eyes and place the implant. Because it's so accurate that even if you don't want to go wrong, you cannot. That's a different thing. But otherwise, chair side guides and all that, it is must and never ever do a flapless. Yeah? So raise the flap, make sure whenever you raise a flap, you have to give a deep cut right till the bone. Your blade should be touching the bone first and then start running the blade. It should not be that when you start, you keep going like this. You will not have a good full thickness flap. For a good healing, for decreased amount of bone loss, limited amount of bone loss, your flap should be absolutely clean. It's called as a mucoperiosteal flap. It should have healthy mucosa and a clean cut in the periosteum. So even if you are grafting and all that, you don't need to place a membrane if your periosteum is intact. Because periosteum is a natural membrane which will prevent any crossing of your fibroblast towards the bone or the osteoblast towards the or any other oral fluids. So make sure your mucoperiosteal flap is clean. Place your implant, and I always suggest placing at the time of placing an implant, initial phases always take an X-ray after your primary drill. That's your pilot drill, 2mm drill. Always check. Maybe prosthetically it is looking good. Sometimes because of the curvature of the adjacent tooth root or the foramen inside, or there are so many other vital organs. Always take a X-ray after your primary drill, once you've done that. Why only at primary drill? Because if you want to change direction, you can easily do that after your 2mm drilling. Let's say if you've already increased to 4mm and now you want to change the direction of your osteotomy, you can still do that, but you will be losing so much of bone. Okay? So after your 2mm drill, always take an X-ray with the drill inside. So this is the final point. Another case, same way. I'll just run through. Anybody wants anything you want me to stop? Just let me know. Because these are all cases. What I'm trying to tell you today is not the photographs. The finer points which you should keep it. These you will get in any address. What I want to tell you is the finer points, the tricky points which you need to keep in mind when you are doing your implant cases. So this is the medical CT we used to take in the initial. This is a very old implant case. Final implant placement and final processes. Now the consideration. in the anterior single tooth. First, we have discussed that earlier, thin labial alveolar plate. Even after extraction, there is always a loss of alveolar plate. That is why your bone grafting after an extraction, which is called as socket grafting. Even if you don't use bone, use a collagen. But it is a good idea to use that if you are not placing your implant simultaneously. You understood what I mean to say? Your patient is not ready for implant in the same sitting, or the situation doesn't allow for immediate implant placement. Always, if there is bone loss, place the bone graft or a collagen to place after the extraction, put the collagen, which will help in building a very good thick soft tissue, as well as will prevent collapse of your alveolus. That is why it is called as socket. What is this procedure called? Socket preservation, they call it. Although it's a wrong terminology, we don't want to preserve the socket, we want the socket to heal. But it's called as socket preservation because we don't want socket to collapse. That is why. Nowadays, you have collagen embedded. Economy-wise, the collagen is the best thing. Whenever possible, always place the collagen if you are not placing the implant. Then remember, this is a cosmetic zone. Your implant has to be precise. At least prosthetically, it has to be precise. You can't afford to have an implant popping out of the gum. Okay, it has to be at the crest level or subcrestal, anterior zone, aesthetic zone. What the patient has come to you for aesthetics, he was wearing a good denture earlier, but since aesthetically not very pleasing, he's come for an implant. And if you don't give him a good implant, aesthetically good implant, what is the use? And if it's a denture, you can just easily throw it away and make a new one. Implant, you won't do that. The surgery of removing the implant after osseointegration is bigger than what you do for placing the implant. So you have to be very precise. Very frankly, I'll tell you, for your initial cases, don't select try not selecting the upper anterior piece. Okay. So cosmetic zone, gingival biotype again, which will also help you in good cosmetics. Gingival biotype here is what type of it is? In the upper anterior. What are the different types of gingival biotype? I should call your professor. Thick and thin. Thin biotype and thick biotype. Okay. Thick biotype is with good amount of collagen. Thin biotype is when it's febrile. Okay, when it's thin. Many a times it is so thin that it is translucent. You can see the implant, you can see the instrument from inside. So make sure your biotype is thick. It's good, well keratinized with good collagen inside. Then nasal floor proximity. Almost 70 to 80% of times you will not have a problem. There is enough bone between the floor of the nose and the crest. You will be able to place a good 10 millimeter implant. 10 millimeter, why I say 10 millimeter? That's the minimum you need to have. If you consider that 1:1 ratio. What is that? Ent's law. Ent's law, crown root ratio. Although that is not accepted by the implants, but still 1:1 ratio is must. So most of the time it is the 10 millimeters, your crown is not longer than 10 millimeters. Okay. So most of the time the bone available below the nasal floor is sufficient. But again, consider that, you have to keep that in mind. Implant diameter emergence profile. This is must in the aesthetic zone. And which is the most aesthetic zone in the oral cavity? Maxillary anterior canine or premolar to premolar. So what do you mean by emergence profile? Emergence profile is how the crown will emerge from the soft tissue, from the gum. Now, how will it erupt? It all depends on the diameter of the implant. If the diameter of implant is, let's say, 3 millimeters, you are supposed to give an incisor. How the crown will emerge, it will have to be suddenly increased in size because the diameter is very small. Suppose this is a 3.5 millimeter diameter implant, and you have to give such a huge central incisor or a molar. So the emergence profile will be sudden. Okay, when it is sudden, the curvature is more. When the curvature is more, there will be a wedge formed between your soft tissue and the curvature. So what happens? There is more amount of food impaction. Plus, to look at also, it looks bulky. Now just imagine if there is a 4.5 millimeter diameter implant, okay, and then there is this bigger crown. So the curve from the crest of the implant to the diameter, the maximum diameter of your crown is very gradual. It's not sudden because already the diameter of the implant is big. So the base of the crown is also big, and the gradual curve will not look bad. It will not form a wedge between your soft tissue and the tooth. It will be like this. So it's auto-cleansing, something close to our nature. But if it is like this, all the food will get stuck. So the moment after the patient finishes his food, if he lifts his lip, you can see what he had. So the emergence profile in the aesthetic zone is very, very important. Then surgical guide based. I've told you earlier, especially your first few cases, at least 40 to 50 cases, should be your based on the guide. Again, I'm not talking about CBCT guide. How do you make a guide? Quickly, I'll just tell you. So make a model of the edentulous jaw or partially edentulous jaw. Make a RPD kind of thing. So you have base and wax up and the tooth over it. Okay. So this will help you in planning your final processes. It will be good for patient education as well as it will help you in placing the implant. Now you have both upper and lower jaw with the implant and the wax. Okay. Now what you do is take a 2 millimeter drill. Don't use your kit cut drill because it will spoil. So take a 2 millimeter drill which is worn out or any local 2 millimeter drill and drill a hole into the tooth and then just put a pin inside. Close the jaw. See if your pin is falling on the opposite. Where should the implant axis should fall on the opposite jaw of the opposite tooth? Should it fall on the cusp? Labial cusp? Should it fall on the parietal cusp? In between what lies? Groove. Okay. So your cusp should be in the groove. That's how the normal occlusion is. Okay. So your pin should be falling on the cusp. Now you are sure that the axial inclination is correct. So extend the drilling into the cast using the same drill. You've done that, take out that. If it's a single tooth, if there are multiple teeth, drill all your holes, take out that wax cut denture. Now you have holes in the cast. So place a toothpick in those holes. So you'll have 2 or 3, whatever the number of implants are. You'll have 2 toothpicks lying like this. Take a gold cure and again make a denture. Earlier it was a wax, now it's a wax gold cure denture. Once that heals, just trim it fine, transfer that to the patient's mouth. Obviously the toothpicks are out now. Now you have 3 holes in the denture. Before the surgery, just take that after anesthesia, just put that in and make your initial drills. You made your initial drills, throw it off. The work is done. Now you give your incision. When you open, you have everything right in place. Make those osteotomies. You want me to repeat? Any doubt? Cast is ready. Let's talk about single tooth. The cast is ready. Opposite cast is ready. You've articulated. Now you know where you want your tooth to be, because that wax pattern, and the tooth is also ready. That RPD, wax RPD is also ready. Place it there. Drill through the central fossa in between two teeth. You can easily see it is not intraoral where there is difficulty in the seeing. You can lift the cast and see all directions. It should be mesodistally centered, it should be buccolingually centered. Drill that hole till the cast. So now you've got a mark on the cast where to drill your osteotomy hole. Take this out. Check that you're in the right direction. Take this out. Drill that, extend that hole into the cast. Place a toothpick. What do you use for your Manchurians? Take that toothpick, insert. And now take the cold cure and form a small denture around it. Trim all the excess. Only that part should be there. Once that cures, throw away your toothpick. Now that denture with the hole is ready, place that into, after sterilization, place that into patient's mouth. After the anesthesia, drill a hole the way you did in the earlier denture. So place a hole through the mucosa before the incision. Through the mucosa, just drill a hole into the bone. Just a small drill. Okay, once that is done, then you start your regular implant placement procedure of incision, raising the flap. Once you raise the flap, you will have that small scoring on the bone, which you made through that guide. Okay, extend that, following the same angulation, extend that, and you will be in the right direction. Clear? Yes, yes. Thank God. First question of the day. Very good. Yes, that's why I gave you an example of only one. I think I've included that in my rest of the lecture. Otherwise, just remind me, I'll show you. It's in a different presentation. I'll show you. Okay. So, very good surgical guide is very helpful. Optimal implant position or contact. This will also help you in spacing out your implants when you're doing your multiple implants. Very helpful in spacing out the implants. Now, why spacing out the implants are so important? If they are too close or too far apart, you will not have very good contact points. The same problem which happened with the emergence profile, same thing will happen in your contact points if they are too far or too close. If it is too close, you will not have that space for the curvature. If it is too far, it will be too steep a curvature. You have to fill up that space between the implants. So that is why this optimal implant position for contact point is necessary, is important. Clear? Single tooth posterior, same. Why? Because of the light, the photos are much more clearer otherwise. I can see very clear. Right. Better now or same? They are better in my. So, simple procedure. Place your implant and closure. There. So this is more important. Reduce residual alveolar height. Almost always. Agreed, ma'am? Almost always. For two reasons. One, why posterior? Because it's posterior maxilla, soft bone resorption rate is also high. So you will have vertical bone resorption. You will have buccopalatal bone resorption. Secondly, pneumatization. The sinus gets pneumatized, so half of it, the sinus gets pneumatized, and then alveolar crest bone loss. So you will most of the time have less bone in this area. So reduced residual alveolar height, functionally demanding zone. So when we say functionally demanding zone, means the implant size and the tooth size eventually should be good. there should not be any problems with the food interaction. There should be good contact points. So keep all those things in mind. You may give good sized molars, but what if there is perpetual food impaction? Patient will not be very happy. And of course, periodontally, it will be periodontally compromised later. Then gingival biotype is again very important for a good periodontal health. Just remember, a thick biotype will always have a thick bone or healthy bone. Or the other way is, thick biotype is always found because of healthy bone. Either way, but it is always like that. A thin gingival biotype will have very thin labial plate or a compromised or too porous labial plate. So gingival biotype will always win. Maxillary sinus floor proximity because of the reduced alveolar height. Implant diameter occlusion form is important because it is functionally important. Backs up is with distance for the contact point. Drilling consideration. Now, this is what it is. Now, drilling consideration, mixed cortical cancellous bone. It is a D3, D4 bone in the maxilla. So, what do you do? Or let's say if it is mandibular anterior, it is D1, D2 bone, very hard bone. You know the composition of D1, D2, D3, corticocancellous, how it is. Anybody wants me to repeat the classification of D1, D2, D3, 4? No, you all know. Okay. So now, what will you do if we are talking about posterior maxilla? It's very soft bone. Sometimes it is so soft that to check, if you don't run your pilot drill and just put it there and try and push, it completely goes in. It is so soft. So what do? Do you place your implant in the same bone? We can do that, but again, PIC. Why it is soft? Because it is more, the inter bone spaces, what do you call that? Trabecular spaces are big. So there is less amount of bone. So obviously when there is less amount of bone, your PIC will also be less. So that means your primary stability will also be less. Sometimes it is so less that after a week or so, patient comes back with the implant in his hand because it has popped out. So how do you increase your BIC or increase the quality of bone? So what is the procedure of your osteotomy? You do a 2 millimeter, let's say if you are placing a 4 millimeter implant. You do, your initial drill is 2 millimeter and then 2.5, 3.5 and 4. That's how it goes. Why 4? Because your final implant size is 4 millimeter. But the diameter of your osteotomy is 4 millimeter? No. Because your last implant drill says 4 millimeter, it is because it is for 4 millimeter implant. The diameter is not 4 millimeter. It is less than 4, maybe 3.6 to 3.7 depending on the type of implant, the shape of the implant, the thread size, everything depending on that. That's why different companies have different. So that's called as differential. If my last drill is 4 millimeter, for a 4 millimeter implant is 4 millimeter drill, the actual size will be 3.7. So it is not a 4 millimeter drill. It is for a 4 millimeter drill, for a 4 millimeter implant. So there is always a differential, which is 0.2, 0.3. So that's how you get your primary stability. Now if it is a soft bone, we want to increase the differential. So what you do is, instead of stopping at 4 millimeter drill, you stop at 3.5. So now when you place your implant, you will get more resistance. So the bone will get compressed. So eventually what is getting compressed? The trabeculae. The size is being reduced. So your D4 bone is turning into a D3 bone. Yes or no? So you will have a better primary stability and more BIC, more bone implant contact. When you have increased high BIC means more amount of osteointegration, more amount of your implant surface is getting attached to the bone. So better stability later on in life? No? Any doubts? Okay. So that's how you alter your osteotomy. Now what if there is a hard bone, mandibular anterior, purely cortical? Most of the time it is purely cortical. And when you go down, then there is some amount of cancerous bone. Now when you place your implant after final osteotomy, that differential is too much. Earlier it was less, now it is too much. Then there is excess compression on the bone, because the bone is already hard. When you are trying to place your implant, it is not able to compress because it's a hard bone, cortical bone. And if you put too much of pressure, there is necrosis. We don't want to put too much of pressure. That is why they have limited this to 35 to 40 newtons, again depending on your thread size. If it is a sharp thread, you can go beyond 50. If it is a square thread implant, you have to be well below 35, 40. So that's how. So now they have set a limit. Now, but you see that when you're placing your lower anterior implant, you're not able to do that because it is so hard. You cross 45 newtons also, still you're not able to place it. Take out the implant. So with practice, you will come to know when you're drilling. You don't need to place the implant and then take out the implant. You will come to know the bone is hard. So what you do is decrease that differential. How you do that? Every implant kit will come with a dense bone drill. They always have series of drills. Then they have a dense bone drill. They will also have a not countersink, the one which forms the thread. Anyway, tap drill. So they always have a tap drill, so that your implant is not working too much and forming those threads. Because forming those threads is drill's work, but your implant was working, implant also has threads. Implant was making those threads because of soft bone. Now there is hard bone, there is excessive pressure, and your primary stability goes beyond 40. So there are chances that your bone undergoes necrosis. So that's why you use a dense bone drill. Now what does that dense bone drill do? It will decrease the differential. Means that dense bone drill for that particular size is, the differential is, let's say 0.2 mm only. Otherwise your final drill, the differential was 0.4 mm. Am I making sense? Okay, have you understood? Okay. So decrease that differential and you will be able to place your implant. Clear? So that's how you manipulate between your different types of bones. So in posterior maxilla, you will increase the differential. In anterior, lower anterior, extreme hard, you will decrease the differential. So now maxilla single tooth posterior is done. This was done already. Multiple. Multiple anterior. Almost the same thing. Now just see this. We've not used any CBCT. We've not used any CBCT guide. We've just used a simple chair-side acrylic guide and check the parallelism. It's not that I'm great, I can do that. It's the guide which has done that. Now the spaces also are equal. Almost equal between each implant. So what do you expect? Nice shape of teeth, the final processes. It will have a nice shape, nice contact, everything. This is the guide we used. This is very funny. So I was telling you, you place a toothpick and then equalize. Just before that toothpick, place a sleeve inside. Where do you get those sleeves? From the cycle shop. These sleeves are the one which we have used here. You can see threads inside. These are the ones where they tie the spoke to the wheel. You've seen them tightening the spokes, the wires in the wheel. So these are the same. So you get a 2 millimeter thing and you can incorporate that before you acrylize. The cheapest thing you can do. And chair side. It takes only half an hour, 15 to 20 minutes, half an hour after your cast is ready. So, and see the parallelism again in your direction indicators. So this is just checking before you go on to your further osteotomy. So this is final implant placement and your soft tissue. This is your trial. Although the final outcome was not all that great because there was soft tissue deficiency. But still, the patient had a bulky lip, so we got away with problem. So consideration in posterior maxilla, everything same. Reduced cosmetically demanding, this is anterior maxilla. Cosmetically demanding zones, gingival biotype, nasal floor proximity, everything same. Number of implants. How many implants if you have missing canine to canine? Means 6 teeth missing. How many teeth should be replaced? How many implants should be placed? We can do with 2 also. Why 4? Ideally 6. The number of teeth, it is always 1:1 when you are in aesthetic zone. I'll talk about it when we come to functional zone. Aesthetic zone always, if the patient can afford and you have your implants in your clinic, always 1:1. Of course, good for your pocket, but good for aesthetics also. Then maxillary, maxillary posterior multiple. Again, I'll just skip through everything. Place your implants, then the membrane, grafting. This is final. This is after. You can see a small space because the cover screws are not fully tight. Why? Because there is a membrane. So the membrane is not sutured, so we've engaged it in between your cover screws. So that's why. So this is the final outcome. So consideration, everything same. Again, come to number of implants. I would again say 1:1. Especially in cases where you are not able to place your implant more than 4 millimeters and more than 10 millimeters in length. 4 millimeter in diameter and 10 millimeter in length. Why? We are dealing with the area where there is maximum forces. And if you place if you're not able to, because of the bone constraint, if you're not able to place a wide implant or a longer implant, the implant will be at risk and later on there will be bone loss and eventually loss of implant. So that is why 1:1 is always better, especially when you're placing 10 millimeter or less than that. If you have longer implants, wider implants, again, bridging, jumping only 1 tooth. Means if you have missing number 5, number 6, number 7, you can place 2 implants. But if you have missing number 4, 5, 6, 7 means both premolars and molars, you cannot place an implant in 4 and then 7 and give a bridge. And that too, especially when you are dealing with massive masticative forces, posterior maxillary implant. You can only jump 1 tooth. Yeah. No consideration. So let's say if you have 10 millimeters of bone between your floor of sinus and the crest. That's called bicortical engagement. So what you can do is select an implant which is more than 10 millimeters, whatever the next size in your implant can be, whether it's 11, 11.5, 12 millimeter. Select that size and then go beyond. You have to puncture the sinus floor and then. So now what is sinus floor is your cortical bone. Crest of the ridge is cortical bone. In between everything is cancerous. That is why there are times when you have problem in getting primary stability. So increase the length and try and engage the floor of the sinus. So that's how you will get good primary stability. Otherwise it has no other advantage. Only thing is your implant size has increased and it has got good initial stability. When I'm saying primary stability, initial stability, this is only till the time it osseointegrates. After that, primary stability has nothing to do with that. The graph goes like this. Initial primary stability is good because that is mechanical stability. The threads have got it. The cortical bone has given you that. But eventually that will fall like this. Meanwhile, your biological stability is zero at that time. Means osseointegration is zero. That graph will gradually rise. And eventually it will give you a good listen. Eventually it will give you a osseointegration, it will give you a biological stability. So, mandible anterior, that's a canine which was sick, bone loss, removed it, placed the implant, grafted. This is the second stage. And this is the final. Again, thinned out crestal. Things to be considered in the anterior mandible. Thinned out crestal residual alveolar ridge, cosmetically demanding zone, but not as demanding as your maxilla. But there are patients who have visible mandibular teeth and less visibility in the maxilla. Gingival biotype is almost always thin. So you need to improve gingival biotype. If you can't do it, contact your periodontist. Implant diameter. Very, very tricky here, and there are multiple teeth missing. Even if there is, let's say, a central or a lateral incisor, mandibular central or lateral missing, you will not have enough bone for a regular 3.5 millimeter implant. If you do that, you will be eating up the bone between your natural tooth and the implant. There won't be any bone left. Again, go back to that bone dieback. When I was saying bone dieback on the labial side, same thing applies even on the mesial and distal side. After the osteotomy, there should be at least 1.5 to 2 millimeter of bone left between your natural tooth or the implant and your osteotomy. If there is no bone in between, you have done the drilling, you are expecting there will be bone dieback and no healthy bone left, the whole bone will resolve. Okay. So, implant diameter emergence profile is must here. Is of very, very great importance. And then surgical guide base legs are optimal implant drilling. Drilling consideration, we have already discussed that. Okay. And yeah.
With a full maxillary rehab. So in that case, if we follow the 1:1 ratio, then it says
Obviously no.
Exactly.
We can still do that. We can still do that if we are able to maintain the inter-implant bone. We can still do that. But then there is no use because you are slinging all your implants. Is one of the question? Yeah, if we are doing the full mouth implants,
जनरली इट्स बेस्ट कि हम 1:1 रेशो को फॉलो करें. अगर हम लोग फुल माउथ की बात करते हैं, ब्रिजेस वगैरह के एस्पेक्ट से अपन बात करते हैं, सिमिलरली मैक्सिला का जो पोस्टीरियर एरिया है, बिकॉज वी से दैट्स द वर्स्ट एरिया. सो इन दैट केस अगर हम 1:1 को फॉलो करते हैं तो वो
That's you mean to say the only number 4, number 5, number 6, number 7 missing. Why don't you place more implants? I'll show you that. It'll be there. There are a few slides showing that.
worst area also it will have the stability.
First area.
Worst area.
Worst area. So you alter your osteotomy. It's not worst area. It is such a nice area to do. To place an implant. Only thing is, it's soft bone. You alter your osteotomy. You under osteotomize and then you get a good primary stability. If you under osteotomize, same thing again. I'll repeat. Same thing again. If your osteotomy is much narrower than your implant. So when you're placing your implant, it will compress the bone around. No, because it's not cutting. It is compressing the bone. When it compresses the bone, it is improving the quality of bone, let's say from D4 to D3 or D3 to D2. Was that your question? The easiest area is mandible, posterior mandible. If you are starting your practice and you need a case, I think this should be your first case. Posterior mandible, premolar, molar. So open, there is enough bone on both the sides, thick lingual and buccal plate. And place your implant, suture. Second stage, your healing abutment, and this is what you get after your healing. Abutment placement and fine. So almost everything same except for number 4. Inferior alveolar nerve approximation. Where does it start? From first, second premolar, because most of the time your mental foramen is in between the apex of first and second premolars. So anterior to the posterior to that, you have a course of your inferior alveolar nerve. Again, just keep that in mind. The inferior alveolar nerve enters the mandible through the medial aspect, through mandibular foramen. So, and slowly changes its course towards the buccal side and exits from the mental foramen. So, throughout that, it keeps moving from lingual to buccal. Why I am telling you that? Let's say in number 7, there are times when you place your guided implants, you place your implant, the implant goes beyond the level of your inferior alveolar. So if you take an X-ray, you will see your inferior alveolar running like this and your implant is like this. In a 2-dimensional X-ray, it will look like that you have impinged the nerve. But actually, if you see 3-dimensionally, it is like this. Your nerve is here, your implant is here. Why? Because at the region of your second molar, your inferior alveolar nerve is much more on the lingual side. But this should be done only after confirmation from your CBC. Never ever try that. You never know your patient has your inferior alveolar nerve more towards the buccal side in that area. So confirm with your CBCT and then only you can do that. So drilling consideration, same thing. Usually posterior mandible has D2, D3. If it is D3, you don't even require any countersink or your dense bone drill. But if it is D2, it's better. Never ever over tighten your implant. Never. Don't cross 35 if you are using a square thread implant. If you are using an aggressive thread implant, never ever cross 60, 70. So there's a friend of mine, he calls me, I've placed great implants, square thread implants he uses. Great implants. I achieved 40, 45, 50 in all the implants. 3 months down the lane, all three were lifted like this from the bone. Reason is very, very obvious. Any good experienced implant surgeon will tell you what the cause of your implant failure. Most of the time it is heat production, whether it is from over tightening or your drills are not sharp or your irrigation is not proper. Next. Okay, yeah, especially this one. Now, this is how do you choose, how do you measure your edentulous site? How do you choose what are the implant sizes you will place? Or when you are placing your initial drill, how will you measure the distance? On the cast, you can draw a circle, erase a circle, again draw that, move your implant here and there. But when you are without a guide, when you are working on the cast, how will you know where to start the initial drill? Okay. So, in general, the formula is you should have bone after your final implant placement. You should have bone between a natural tooth and implant 2 millimeter, between an implant and implant 3 millimeter, same way 3 millimeter, and then 2 millimeter. Why? Or how will you measure this? This is after your final osteotomy. But when you are starting your osteotomy, how will you measure this? So just add half of your or radius of your implant which you planned. If you planned a 5 millimeter implant, add 2.5 into this. So it becomes 4.5. So your initial drill from this tooth should be 4.5 millimeter. So, and always do your initial drilling when you are placing your multiple implants. Don't finish one implant and then go for the second one. You never know, don't get placed for your third implant. Okay. Once you've done your initial drilling and you see your final, your direction indicators, once you insert, will give you a diameter. It has a bigger diameter on top, which gives the indication how big will be your implant. Because the bigger diameter of your direction indicator is the size of your final implant placement. Okay. So you can use that and see where your final implants are and what is the gap between them. We'll show you once you have kit in front, then we'll show you. Okay. So you've done that measure. You understood why radius, why half of it? Because it has to be in the center. If your total width of your implant, diameter of your implant is 5 millimeter, means from here till here is 5 millimeter, and from mid to this is 2.5 millimeters. So your initial drill will be here. So that's from where you will measure 2.5 and 4 millimeter from your natural teeth. If you had done this calculation, this mathematics on the cast, it becomes very easy during the surgery. Just see, because of that, how good the spacing is. If you have good spacing, you can even have good interdental pattern. Clear? The other method is, one is your guide, the other method is there are spacers available. So what you do is you have to measure only the first one. From tooth to here, you put this, then you put this pin inside and you have a spacer of various lengths. You have 2 millimeter, 2.5, 3, 3.54. It comes as a kit. So this spacer has a small 2 millimeter hole here. So you put this pin inside and pass your initial drill through this. It will give you exactly gap of 2 millimeter and exact parallelism. You understood? Okay. So this pin is on this side also and this side also. So now this pin is already inserted into the second osteotomy. Now see, there is not enough space for the third implant. So that means we have to reduce the size. So I'll just change this pin and get a smaller one, smaller spacer, and then place the. You'll come to know where once you start doing the implant methods. These are all later on. But initially your best is your guide. So draw this diagram on your cast. Draw the drill holes over here. Make sure they're parallel. Put your toothpicks in this. Put those sleeves if you want, and then acrylize. The only advantage of that sleeve is it will give you a thickness and it will not allow your drill to bend. Because otherwise acrylic drill, if you bend your drill, it will drill the acrylic also during your initial drill. So the only advantage of this sleeve is it will not allow your drill to bend here and there. So you will have exact measurements. Now just see the spacing. Good. Everything same. Next, what are the other this thing? You have mini implant supported dentures, you have conventional implant supported dentures, you have implant supported bridge, and then hybrid processes. Again, cases of each. This is totally edgeless and mini implant supported. See, these were called as transitional implants. Transitional implants were, earlier there was nothing called as immediate loading. When we started our implant practice, it was same Kalmish and the older protocols of do the extraction, wait for 3 months, again drill, place the implant, wait for 3 months and then get. This is mandible. Maxilla the other way. Do the extraction, wait for 4 months, then again drill, place the implant, wait for 6 months and then give the processes. Simple, but easy life. Nowadays it's more difficult. Okay. And so in between that waiting period, if the patient still wants some more stability to the denture, so they came out with 2.5, 2.8 very thin implants which were placed in between your regular implants. For that transitional, the waiting period of 6 months. So they were called as transitional implants. So they were placed and then denture caps were given onto that. But later on, India being a very, economy-wise, not a very rich country, so they came out and they started using these transitional implants as permanent implants. So that's how they look. This one, these are transitional implants. These are your permanent implants which are under healing phase. Fine. These are your regular implants. These are transitional implants. Can you see that? These are the regular ones, these are transitional. So after the healing phase, once you start loading these, sometimes they came out very easily because most of the time they don't osseointegrate. Sometimes they were osseointegrated that we had to just cut them from the crest and then you have a choice of your O-rings or the bars. The only bars are very good stability advantages for the bar. One, it requires a very good vertical height. Very good clearance. Have a good vertical height of your jaw. These are not meant for us because they need good clearance, the good gap between the crest of maxilla and the crest of mandible because they themselves are bulky. Secondly, patient is not wearing the dentures, then they are very uncomfortable because they cannot be taken out. They are screwed in. That's how it is. So these are two screws here, two screws here. For the mandible. And here you can see these are the transitional implants which have been just cut off from the crest of bone and they are left inside because they are all osteoclated. But they are not very good in stability. Full mouth, patient came reported with multiple retained roots. So we removed everything. This is a two-stage. Removed everything, waited for this to heal. The bone healed nicely. This is the guide. Placed the implants. There was not enough bone in the anterior maxilla. The nasal floor was, the crest and the nasal floor height was not enough. So we did not place any implants in the anterior region. Multiple implants, upper and lower, all prosthetic steps. Fine. So from here to here. And I have a question. Okay. If you're very lucky, you'll have a totally edentulous patient with good vertical height of maxilla and mandible. Most of the times you will not get that, but in severe cases, then we don't prefer full mouth, we don't prefer a bridge. We cannot give a bridge because the vertical height of your crowns will increase. In those cases, we prefer hybrid processes. Hybrid is, there is something in between your implant and final prosthesis. So that's why it's called as a hybrid prosthesis. So this is the case, again, using a guide, implant placement. This was because there was not enough height between the crest and the inferior alveolar, so we placed only in between the foramen and 5 implants. Here, because they are all splinted and we are doing a hybrid, the another advantage of hybrid is we can give a long cantilever. Just see in this how long is the cantilever. We can do that because one, it is a hybrid. The load is from the implant is transferred onto the hybrid metal. It's not directly transferred to the implant. So from occlusion to the hybrid and then to the implant. So it is dissipated through this. So that's why you are able to give a long cantilever in this case. So residual bone not sufficient for full mouth bridge. That's what I said. Number of implants for hybrid is less than for the full implant rehabilitation. And then fixed processes. I mean, this is a fixed processes option. Reduced load. This is what I said because it keeps dissipating load throughout. Since they are all splinted and there is a hybrid in between. So eventually will lead to longevity of your prosthesis. This is again, okay. Morning I said you can use your existing denture as your guide. So this is the patient who was wearing the complete denture over the retained roots. So we converted same denture. We just opened up the denture from the palatal aspect, just keeping all the teeth. So now these teeth will give us a guide where all do we drill. So we removed all the root stumps and exact angulation was guided by the existing. So after your initial drilling, you can remove this and then open up the flap. Once you open the flap, then you have full view and then you can finish your osteotomy. This is your suturing. This is what we took out. See this now. So the stability was gained from one of the molars which we retained so that it doesn't move when we are, because after we raise the flap, the adaptation of your implant, the stability of your denture is not so good because there is flap inside, there is loose mucosa. So it was a good idea to retain one of the molars. Maybe end of the surgery you can remove this, but retain one of the molars so that you have good stability of your denture. And there are 2-3 times when you take it out, you again place it back, so that you are able to place it in the same place. And then place the implant. The tooth which was stabilizing initially is out now. Just a small teaser for your what exactly is sinus lift. Just briefly, you should let you. Although you in your practice, even if you're not doing it, you should know, because I know so many dentists who have attended our courses, learnt everything but are not practicing. And they were very clear from the beginning that they will never practice. They are doing this only to gain the knowledge, to know what it is, how to convert the patient, how to convince the patient. You will not be able to convince unless you know in and out of that implant. So if the patient has, and implant patients have so many questions, if they question, you are able to answer it. Finally, she used to call some other implantologist, some oral surgeon for all the procedure. So same way, just a brief knowledge of what is sinus lift, when is it advised, and how it is done. Maybe you are not doing it, but just to explain it to the patient. So now if you see this old extraction, there is decreased vertical height. You can see the arch formed over here. So decreased vertical height and decreased bucco-palatal width. So both are deficient. So open a flap, proper clean mucoperiosteal flap, and make a small window. So you can use even a diamond tip burr, you can use your bone cutting burrs, or you can use your piezo. So whatever you use, everything, all are good. This Call Medi has come out with a absolutely safe kit. That's what I've started using now. It's Okay, so we won't waste time now. We'll explain you when you're doing the hands-on. So this was done with a burr. So what you do is keep drilling very slowly and remove only the bone. You don't touch the membrane inside. Once you've done that, you can just compress from top and see if it is completely compressible. That means you have removed the bone all around. So this has been formed into an eyelid. Once you do that, then you just keep releasing. There are special instruments there called as sinus curettes. Keep releasing your membrane from the sinus wall. Now you know that bone eyelid has gone inside. So once you keep pushing that, this area you will fill up with the membrane. Earlier, this was the floor of the sinus. Now the new floor of the sinus will be this. Because you've lifted that, this empty space is filled with your bone graft, and now this is the new sinus floor. Your sinus floor has gone up. There have been cases reported where chronic sinusitis patients have been treated automatically, unknowingly, by mistake. They've been treated. Why? The problem with chronic sinusitis is the sinus membrane, the Schneiderian membrane inside, has cilia. We all know the histology. They have cilia. What is the function of cilia? To push the discharge into the nose through the ostium. So if your sinus lining is diseased, it will not be able to push the discharge into the ostium and finally through the nose. So that's why it is called as, it converts into chronic sinusitis. Now what you have done is raise the floor of the sinus. You brought it close to the ostium. The ostium is in somewhere here. The sinus floor which was here, you brought it up. Now the cilia have to work less. So they are able to drain the mucus nicely. So your chronic sinusitis is automatically treated. And there have been cases reported. So you raise this empty space is filled up with bone graft. So that's your new sinus. So bone graft can be, this we have taken it from tibia because we required a big amount of cancellous bone. But otherwise you can use synthetic bone, you can use autogenous from mandible, angle of mandible, anywhere. Mix it, because this is purely cancellous, this resorbs really fast. Although it has good bone proteins, but the only problem is it resorbs very fast. So you have to mix it with some long resorbing bone, maybe beta tricalcium or any other synthetic bone, which takes time. So you mix both of them, so you have an advantage of retaining that space, as well as you have bone proteins, excessive bone proteins, to form good bone. So you mix them and place it. So if you see, initially the floor was here, and now the floor is here. This is the new floor. So you are able to place a decent size implants. Can you make out here? Can you make out here? Can you see these two? This is the new bone level. I mean the sinus floor. And here also this is the new sinus floor. You can see a little bit of bone graft still there. Just another case where there are again deficiency, too much of dip on the buccal aspect. This was completely resolved. So we had to augment buccopalatally as well as raise the sinus. So we took the bone graft from the angle of mandible, did the sinus lift procedure and placed this bone block on the buccal aspect. And now if you see after the healing, see the bone level, this is before, you see this dip here, see it's absolutely straight. The thickness has increased. Here if you see, this is the initial and this is after the sinus lift. You see this bone and then finally implant into the bone. Somebody had a question, 1:1 in posterior. 4 teeth missing, 4 implants. I'm not saying it's just because you want more money. Functionally, it is better. Now, why we preferred 4:4 here, 4:4? Although we were able to place long implants. Reason, these implants are in the grafted bone. Even after maturation, you can, throughout your life, you can never compare, at least histologically, your native bone and the grafted bone. Grafted bone will always be inferior to your own natural bone. You cannot compare nature, you cannot defeat nature. Your natural bone has no comparison. So that is the reason, because you never know when the resorption starts. That's why we've given a 1:1. Okay, so this is I've just added that case. This is a very interesting case. So this patient reported with a huge ameloblastoma. So we did a mandibulectomy, we did a grafting, and reconstructed the mandible. Now the question was, this is after reconstruction. Now the question was dental rehabilitation. So first we planned that we should wait. So we waited for 9 months. After that, this is the deficiency. But still, the curvature, the architecture was still acceptable. So we opened it up. We had a good platform thickness wise. It was nice. We ended up placing 4 implants, and we again, I'll just go back. Since you see the height of the bone, so what type of processes should it be? Sorry? Hybrid. Even if I place, the implants are same in both hybrid and all. So once I place the implants, if we place an implant here, just imagine lower incisor this long, longer than the maxillary incisor. Will not look good. That's why to fill up this space, so half of it will be hybrid framework and then your teeth. So that's what we planned. So after that, these are multi-unit abutments which you place for your hybrid. Then your jig trial and all these prosthetic steps. And this is the final outcome. And this is your hybrid framework. Your teeth start from here. If you don't give a hybrid, your teeth will start from here. So almost halfway we have filled up with your gum and jaw looking hybrid. It looks like a jaw, no? See this? It mimics your jaw and gums. So then teeth start from here. This is the final process. So from here, sorry, this is another case. Again, amyoblastoma, excised, fibula reconstructed. After that, with decent mouth opening. Now the only problem in this case was because it was a composite graft with the skin in, you had hair growth on the metal. So we have advised the patient to undergo laser therapy, but affordability was the issue. So this, we used to shave every time we used to come. So this done. Then the bone, if you go the flap over it had too much of fat, because under the skin what you have is the fat. Too much of fat, so we couldn't get a good, the abutment size, because the flap was too thick. So what we did was liposuction to reduce the thickness of the flap. Too thick a flap is also small. So to reduce the thickness of the flap, we remove the rim of that skin from there, fat, skin, everything, and this is the end result. Okay. Another bomb blast case from Iraq. So this guy had lost one eye, nose, lower jaw, both the limbs and one arm. So he was on a wheelchair when he came. So along with dental rehabilitation, we placed 3 implants on the face for the nose. And we actually placed 4. There was another one over here which we lost. So eventually 3 implants and then the dental implants. So they were all really rehabilitated, although not a very great looking nose, but still better than having no nose. And then dental rehabilitation. So general consideration, implants are not always only for dental rehabilitation. They have role in space gain, they have role in anchorage, they have role in distraction. Approach is must. It is not oral orthodontist or periodontist. It's not always like that. I cannot do perio surgeries better than a periodontist. They cannot do oral surgeries better than oral surgeons. So it's that way. They're all masters in their own field. So interdisciplinary approach is must. Great confusion and can you connect your teeth to the implants? So what I mean to say is if you have number 5 and number 6 missing, number 5 and number 6 missing, then you place one implant in number 5 and connect your bridge to for the second molar, which is a natural tooth. Can you do that? Yes, easily. That will save money, that will save everything. But it will increase your headache. Why? What is the end result of placing an implant? Osteointegration, which is something like ankylosis, means there is no micro movement of your implant with the bone. It's completely fused. Yes. And how is the physiology of your tooth? There are ligaments in between the tooth and the bone. So there is an inherent mobility in the tooth, natural tooth. It keeps moving, more in the evening, less in the morning, and all that. All your horizontal fibers, vertical fibers, all that. So now just imagine if one pillar is moving, the other pillar is fixed, means this is your natural tooth, this is your implant which is not moving at all. So whenever there are occlusion forces, this side of the bridge will compress a little, it will go down, but this will not go down because it's an implant. So what will happen? Either your crown will break, or your abutment will break, or the abutment screw will break, or your abutment implant neck will break. That force will go somewhere though. The one which is over here in the natural tooth, it is absorbed by the periodontal ligaments. But here it will not get absorbed. It will be transferred onto somewhere. Even if nothing fractures, there will be bone loss, crestal bone loss. Because there will be more forces and the load dissipation will be finally onto the bone. So there will be bone loss and eventually loss of implant. So during a healing phase or for some time, you can still connect. But connecting your implant to the natural tooth, it should always be with a temporary cement. It will never be with a final cement. Reason? In case there are any abnormal forces or anything, your bridge will get dislodged, which can be cemented back. But nothing will happen to your implant, abutment, screw, bone. So, connecting your implant to a natural tooth for good, strictly. Maintenance and failures, they have to be recalled regular basis. Depending on the processes, depending on the patient, how he's keeping the hygiene, everything. So you can fix 3 months, 6 months, yearly, but you have to recall the patient. Clinical, when your patient comes for recall, you can do a clinical checkup, you can take radiographs, like for all full mouth. First thing, before we make the patient sit on the chair, he's in the X-ray room first. Take an X-ray, see the bone levels, then see the gingiva, see the overall oral health. Then ailing, failing implants again is a separate topic. You have to identify by your clinical symptoms and your bone loss. Any other question? Any doubts from this presentation?